presentation on the treatment-based classification approach to a patient with recurrent low back pain. So the purposes of mine, as other people have been saying earlier, it's essentially the purpose of this. I want to hopefully teach you guys something, and I want to learn something as well. Maybe get some feedback about stuff that I never thought about. But one of the things on my last two clinicals where I was at, they like to take a more tissue-specific approach than we learned in school. So I wanted to discuss methods for you guys about how you could take that tissue-specific approach and kind of integrate it into what we learned in school from more of an impairment-based and not classification-based. All right, so what we got from the order and intake paperwork, all we got was eval and treat for low back pain, which is not really helpful. 41-year-old male, his chief complaint was lower back pain. The onset was in November of 2016, which is about a month prior to when we saw him. He wrote down as his occupation that he was a manager at a bank. There was no relevant past medical history. And by looking at his body diagram, you can see that he just had midline lower back pain. The initial outcomes that we got, his oswestry was 25 out of 50, which is 50% disability. And his start back tool was a 4 out of 9. He agreed with 2 items that were on the psychological subscale of the start back, which places him at medium risk for having a poor outcome. Subjectively, once we brought him back and talked to him a little bit, he stated he had midline low back pain, essentially lower lumbar. It was primarily central, like right over the spinous process, with a little bit of radiation laterally, about maybe 1.5 inches on either side of the spinous process. He first noticed it about a month ago. He got up out of bed, nothing abnormal, no change in his activity, anything like that. Took his first step out of bed and noticed really severe low back pain in that area. Said that he hadn't, no specific event, he hadn't taken up any new exercise or anything before that. But he reports that he's had a long history of that kind of pain going back about 20 years to when he was a UPS worker. Initially one day he said he was bending down to get a box, flexion, rotation, stood up, noticed that same pain. It comes back once or twice a year, every year. Usually dissipates in about 2 weeks, but this one had gone for a month, so we decided to come to physical therapy. Symptom behavior, currently he was at a 3 out of 10 pain. Occasionally get down to a 2, but at worst it's a 7. So normally he's got a deep, constant aching pain in that area of his lower back, but it turns into a stabbing pain when he bends forward, which was kind of his big motion. So his big aggravating factor was forward bending. An issue he had with that was he was a manager at a bank. So what he liked to do was go up behind his employees and look at their desks. If they were trying to show him something, he'd lean forward on their desks because they were lower to the ground. He had a lot of issues with that. Had difficulty standing for a prolonged period of time, sitting for a prolonged period of time, standing up from bed first thing in the morning, and then walking as well. Easing factors for him were just laying supine and then putting an ice pack or a hot pack on his lower back. Activity limitations, transferring. He had difficulty going from sit to stand. Mostly the problem that he had pain with was when he was sitting, he would flex forward to try to propel himself upward. That was the part that was painful of the motion. But he rated that a 6 out of 10 on patient-specific functional scale. Ambulation, he was unable to walk for more than 5 minutes before having to stop and support himself on something, which is a 2 out of 10. He said it was pretty difficult for him because in the Jacksonville area, there are a lot of big buildings that have huge parking lots. So a lot of times you're walking for more than 5 minutes to do anything that you need to do. When dressing, he had to avoid trunk flexion when trying to put on his pants and socks and shoes. Essentially for him, that looked like just pulling his leg up to his opposite knee to don those garments. And then exercise, he was no longer walking for exercise. He normally walked about an hour a day for exercise. His goals, he wanted to walk for more than an hour without pain and be able to sit for greater than 2 hours. So when you work in Northeast or Central Florida, you'll notice that most of your patients' goals revolve around Disney in some way. So he had a trip upcoming to Disney World. He wanted to be able to walk around for a little while and then also sit for the entire drive down to Disney World without issue. So we looked at the SINS model, marked his severity as moderate, from that pain rating being about 2 to 7. Irritability was mild. When we could recreate his pain, it would last for about 30 seconds before kind of calming back down to that low 8. So his T3 was pretty low. The nature of it, just based on the aggravating easing factors and no distal symptoms at all, we thought it was nociceptive, just mechanical low back pain because we could recreate it with movement. Being that it lasted for a month in this stage, subacute, you can make the argument to call it subacute on chronic, just based on the long history of it. And then it was stable. He had noticed no change at all in the past month. Symptoms had gotten no better, but also gotten no worse. So my hypotheses, as far as the category goes, just based on the limitations with prolonged movement and everything, I was thinking stability. Just behind that, I was thinking a little bit of mobility, just with his difficulty bending forward that he reported. As far as the tissue, that was the pain generator, which is one of the things that we were making it a goal to identify. We ended up deciding we thought it was probably a disc issue, more of like an internal disc disruption, which we'll talk about a little bit on the next slide. And then secondarily up there, we thought it could be some sort of muscle spasm happening. So why did we think it was an internal disc disruption? Essentially, for those of you that don't know what that is, it's a chemical change inside of the disc that can cause annular tearing. So you're not getting the nerve root irritation at all, which is why you're not having pain down the leg, but activities that stress the disc really cause the pain in the low back. So according to Siegel, most patients that have IDD experience dull, diffuse aching in the lumbar spine at rest, check. Lancinating pain with movement that stressed the disc, check. Sensation of a weak, unstable back. He didn't say that at all, but when we looked into it, he did actually have an unstable back. A varying degree of sitting intolerance, check. Lifting injury to the spine, check. And then slow guarded active motions, which we hadn't looked at yet, but it turned out that that was also true. From an objective standpoint, watching him walk into the clinic and then watching him walk throughout the clinic, we noticed that he had a shortened stride length bilaterally. We didn't know if that was related to something biomechanical, like an issue with hip motion, or if that's just kind of the way he walked. And then with posture, he had an increased lumbar lordosis at rest, in standing and in sit. So his active motions, lumbar range of motion, we called it about 50%. He was able to get his fingertips to his mid-shins, which was painful for him. He noticed juddering during forward bending, and then he'd have to walk his hands back up. And then extension, he would have about 50%. Left and right rotation, 25%. He had an increase in pain with that, and then some compensatory side bending when he was rotating. And then left and right lateral flexion was about 75%. And we tried repeated motions with him. No better, no worse with flexion or extension after 10 repetitions. We had hip active motion. They were all normal, except we noticed when he was extending his hips bilaterally, he would have a hinged lower lumbar. We called it about L3, L4. Passive range of motions, which we tested in sitting on the edge of the mat. His flexion was 75%. He noticed an increase in pain, which is why we stopped, but it was an empty infield for me. I'm pretty confident I could have gotten him fully through that motion. Left and right rotation within normal limits. We got to the end of that motion before he experienced his pain. Extension, left and right lateral flexion, and all hip passive range of motion was within normal limits. Resisted lumbar testing, which was performed in the same position as the passive, was strong and painful. Resisted extension, everything else was normal. But you got to remember, these muscles are generally pretty strong in most people, so it's rare to have a weak finding throughout these motions. Resisted hip testing, all strong and pain-free. With joint mobility, we noticed that he was pretty hypomobile throughout the thoracic spine with PA pressures, and in the lumbar spine, he was hypermobile with spring testing, L3 through L5. And then with PAs, he had pain at L4 and L5. So we wanted to see how his muscles were activating as well. So the lumbar multifidus, we called it core activation versus both the obliques and the psoas major. So essentially, the action of the multifidus is to activate eccentrically to control rotation that would occur at the spine, whether or not it's being pulled forward by the obliques or by the psoas when walking and flexing the hip past 90. As transverse abdominis activation was fair, we called it, but poor isolation. So when cued to do like your typical transverse abdominis cue, I always try to pull the bones on the front of your hips together. When he did that, it was more of an ab brace, kind of everything was activating. But when we cued him to do a pelvic floor contraction, like he was able to activate the transverse abdominis without anything else really kicking on. We noted a prone instability test that was positive at both L4 and L5. His straight leg raise, he had 90 degrees on the left and 93 degrees on the right before his low back pain started. There was nothing distally with that. An increased turgor and tenderness in his bilateral paraspinals and quadratus lumborum. So my clinical impression, we called it subacute low back pain with motor coordination deficits, which would be your treatment-based classification type diagnosis with probable lower lumbar internal disc disruption. I put excellent for the prognosis. This is maybe one of 3 patients I ever said that had an excellent prognosis. And we'll get into that in a couple slides. The plan of care we wrote for 2 times a week for 8 weeks. We were pretty confident that he was going to see improvements in symptoms before that. We wanted to make sure that we would treat him for long enough to really take care of the cause and the underlying difficulties with stability. So we used as our comparable sign, the pain with lumbar spring testing and hypermobility, prone instability test, and lumbar active motions. So our treatment focus was initially just going to be lumbar stabilization, motor control in the lumbar region, improving thoracic mobility, and then providing the optimal stimulus of repair to the disc. So the optimal stimulus of repair, it's essentially, it's not really a theory, but it goes way back, and it discusses for whatever the type of tissue that you're using, the type of mechanical stress you need to place through it to really stimulate that tissue for repair. So the disc made up mostly of type 1 and type 2 collagen. For type 1 collagen, it would be modified tension through the line of stress. So it's essentially tensioning the annular fibers that lie diagonally to each other. And then for the type 2 collagen, it is compression and decompression with gliding. So we tried to incorporate that into our traditional treatment as much as possible. So looking at our ICF model, his health condition we called decreased lumbar motor control, which is also the impairment. And then possible IDD impairments, decreased lumbar motion, hypomobility in the thoracic spine, and the decreased lumbar stabilizer activation. Activities, he had pain when walking, bending forward, participation, having difficulty supervising his employees and exercising. Environmental factors, once again, the North Florida factor, just this upcoming trip to Disney was going to be difficult because there's limited opportunity to sit. And then he had a cruise upcoming as well, which was good for him. Personal factors, he was a pretty young guy and had a previous positive experience with PT for an unrelated issue with his shoulder. So he had a pretty good idea coming in what he needed to do. He was really motivated to get some exercises and get working at home. So why did I say that he had an excellent prognosis? All 3 of the second years in the room should have noticed that he met the CPR for stabilization or benefits from stabilization from Hicks. So age less than 40 years old, he's 41. I won't call that one a no, but I won't call it a yes just to be strict. Straight leg race greater than 91. He had aberrant motion, definitely, and then the positive prone instability tests. So talking about the rules here that were proposed in that article, the improvement rule down here at the bottom, the improvement rule states that if they meet these criteria, that they'll have between a 6% and 49% change, or positive change on their oswestry, and then the success rule right above it would be a greater than 50% change in disability according to the ODI. And you see, based on the number of variables he had present, that he had a pretty solid likelihood of seeing those kinds of changes. So essentially, I broke my intervention down into 3 phases. The first phase being tissue healing, symptom reduction. We really wanted to work on those optimal stimulus regeneration exercises and decreasing muscle guarding he had in the lumbar spine. And then we would move to the foundational phase, which was building up his mobility, coordination, muscular endurance. And then the third phase being return to function. So getting back to forward bending like he needs to, walking for exercise, everything he needs to be able to do at home. Now it's important to note that these 3 phases are not mutually exclusive. You can do 1, 2, and 3 at the same time, just depending on how you phase out your treatments. So some of the more phase 1 type interventions we focused on, we did a lot of lumbar rotation oscillations initially, grades 1 and 2, to decrease some of that muscle guarding, just get oscillatory effect through there. Paraspinal kneading to help further decrease some of that muscle guarding. And then we provided thoracic BA thrusts. What we got through the thrust was not only did we see an improvement in thoracic mobility later on, but almost immediately afterwards, he would have a pretty big decrease in paraspinal guarding throughout, even in the lumbar spine. And then exercises, we did lower trunk rotations, which was a big part of his home exercise program initially. The point of these is just to provide some oscillation through the low back for the muscle guarding, as well as giving optimal stimulus of repair to the disc. And then anterior pelvic tilts, which for another 2 purposes. The first, getting more blood flow to the multifidus to help decrease some of that guarding, as well as improving lumbar muscle control and activating the multifidus. phase 2 interventions, I included the thoracic PA in here because we were eventually getting some mobility improvements with that. Every time we would do the thoracic thrust, we would follow it up with thoracic extension over a column-borne wedge, just so we had an active component after the manual to help really reinforce that stability, help gain stability through that new range of motion. We did a lot of stuff like posterior pelvic tilts, which is another part of this home exercise program initially to build some segmental lumbar control. First couple visits, we tried transverse abdominis activation on the stabilizer cuff and tried to make sure that he could keep that stability against lower extremity movements. Prone hip extension to make sure the multifidus was activating like we wanted to. We weren't seeing any like compensatory pelvic lifting. After we felt that he could do those comfortably, we moved on to a dead bug type exercise, which essentially is working on maintaining a stable lumbar spine while moving the upper and lower extremity. We also incorporated some seated resisted rotations, which is just to build some more of that lumbar motor control against oblique motions and really make sure that the multifidus is activating like it needs to. And then the last 2 exercises that we did during this phase were called multifidus curl downs and multifidus curl downs with rotation. That's a weird exercise for a lot of people, so I do have video of it. And I hope the computer doesn't like completely shut off when I try to exit out of here. We're going rogue, but I've got a video pulled up right here. So essentially the purpose of this exercise, what you're going to see her do is pull the cables up to her chest, and then she's just going to bend down, like turning herself into mush, not using a hip hinge pattern. But the purpose of this is essentially to improve lumbar segmental control. If you're moving everything as a unit, you don't really get to build that control through the individual segments. So while that control through a hip hinge pattern is important, and we address that a little bit later, we also want to make sure that she can control every individual segment in her spine as well as possible. All right. So visit 5, during my last couple of clinicals, one of the habits we picked up was to do a formal reassessment every 5 visits, just so you can kind of check your progress. But it turns out that 2 days prior to that 4th follow-up or 5th visit, our patient got rear-ended at a stoplight. Unfortunately, you can't control other people. So when he came in, he reported mild soreness in his lower back. It did have an increase in paraspinal turgor, though we had seen a big improvement in that since the evaluation. So just to rule out anything crazy, we palpated over his vertebrae, did a neuro screen. There was nothing wrong with any of that. That treatment, we focused more on manual therapy and like gentle lumbar motions just to kind of calm everything back down. So we didn't do our reassessment that visit. We ended up reassessing it at visit 6. So we'd gotten his oswestry down to a 3 out of 50, so 6% disability. Start back with 0. Lumbar active motion was normal, like get his palms on the floor. No pain with lumbar PAs, but we did still have mild pain with spring testing, just pressure on the transverse process. He would have 2 out of 10 pain after he'd walked more than a mile. Patient-specific functional scale, the average was like 8 out of 10, so he was pretty good. But he had expressed the desire to continue treatment in order to ensure that the problem doesn't return. We felt good about that because we thought we'd done a pretty good job clearing the smoke out of the way, like decreasing his symptoms, but we weren't sure that we'd really put out the fire yet to address all those concerns. So we got more into our phase 3 interventions at this point. So that included like up chops, down chops, a lot of flexion rotation focused movements, a squat with a chest press, which is essentially focusing on a hip hinge pattern, squatting down low with a ball at your chest, pressing it out while you're in your descended phase, bringing it back in, and then standing it back up. So it's essentially just mimicking using the hip hinge pattern and then having to hold an object out in front of you. So you'd have a flexion moment that you'd have to overcome. He did really well with that. He kind of required the normal cues at first, like get your hips back, keep your chest up, all that good stuff. One of the more specific interventions we would do for his walking, he would have be standing in front of a pulley. He'd have a strap underneath his arms that were pulling him into flexion. He would have to maintain an upright posture while marching to 90 degrees and keeping the weight stacked still. So it's essentially another exercise in making sure that he's activating his lumbar spine and that he's not seeing changes when he's marching his legs back and forth. We would progress that by hooking another pulley up to his leg, having him perform full hip flexion and extension with that same resistance at the spine. And then we would have him walk for exercise at home. So we didn't have to do it in the clinic. So we encouraged him just to kind of take a graded approach to it. First day, maybe go walk for 10 minutes. Do that for a couple of days. If you have no issues, bump it to 20 or 15 until he got back to walking about an hour like he normally would. How we dose these interventions throughout. Generally, we either dose for tissue repair, motor control, or endurance. According to the Oleg Grimsby textbooks for tissue repair, you're going to work at about 0 to 50% of your 1 rep max for 1 to 5 sets, 10 to 60 reps. There's a lot of research out there that shows that to get true optimal stimulus of repair to the discs or to any sort of tissue, you need hundreds and hundreds, if not thousands of repetitions a day. So I was having him do these at home, 3 sets of 50, 3 or 4 times a day, or whenever his back would feel flared up. Motor control activities, the same thing, 0 to 50%, 2 to 5 sets of 30 to 50 reps. And then we would dose for endurance as well once we got a little further on down, which was about 50 to 70%, 2 to 3 sets, 24 to 30 reps. Full disclaimer, did not once look at his 1 rep max, so it is what it is. But we did dose using the sets and rep numbers. We ended up doing a discharge at visit 11. Unfortunately, during this care, we got into a new year. Insurance being what it is, his deductible went up, hadn't met it. So his copay jumped from $5 to $85 a visit, which is really financially limiting for a lot of people to come to a treatment twice a week when you're paying $85. But anyways, at that visit, we've gotten his patient-specific up to a 10 out of 10. Lumbar active motion was normal. Spring testing, normal. Prone instability, negative. ODI 0, start back 0. He was able to walk for up to 3 hours, but that wasn't limited by low back pain. Who has time to walk more than 3 hours every day at home? A lot of people have stuff to do. So some of the limitations, I really wish that it had some stronger objective measures. It's pretty subjective on my end to assess his multifidus and transverse abdominis contraction and track that throughout the thing. Maybe we never got that better, but I was just palpating in a way that made it feel like it was turning on. I wish that due to his issues with sit to stand, I probably should have gotten 5 times sit to stand just so I could track that throughout. I thought that I could have been a little bit too conservative on visit 5. The issue, or when he came in, it had been rear-ended. Maybe that visit I could have used to actually work on building stuff up rather than being so conservative. And then initially when I saw that he had some psychological factors on the start back, I could have administered a pain catastrophizing scale to see whether or not he was ruminating, helpless, magnifying, in case I wanted to go down that route and really try to address that later on. And then also, first time I reassessed, which ended up being in this 5th follow-up, most of his comparable signs, other than spring testing, were back to normal. So I should have picked some other comparable sign to track his progress through the rest of the treatment, but didn't end up doing that. Acknowledgements, I'd just like to look out for my 2 CIs that helped with this project, Dr. Ashley Samuel and Dr. Justin Zitch. They were a great help. Really learned a lot from them. All right, does anybody have any questions? Oh, Fit. He's a fellow in training. He's in the Brooks Fellowship right now. He was giving me a grief because he just took his OCS and he's in the fellowship program. And he knows the other girl. He's like, man, why'd you give her so many letters? And he gave me nothing. So I gave him something to acknowledge that he was at least doing some kind of training afterwards. We made that one up. They called themselves the Fits, but we put it on there. Yes.
So you don't have trouble sitting still with all this talk about issue-specific disc.
Oh, I know. I saw you squirming in your chair the whole time.
So, given that he had all of these, given that he had significant psychosocial risk, recurrent episodes, talk about the START results, and the literature that talks about the percentage of people who have disc issues and have absolutely
Absolutely.
Have you considered that you may have done harm? How are we going to prove that? By being tissue specific, and I'm making the assumption that you talked like that.
Actually, that is not something that we ended up talking about with him. Just from clinical practice, there are some of your patients that want to know a whole lot about what's going on. They want you to get really in-depth outlooks at what they're doing, and then there are some of the patients that could care less as long as you get them better. So the education we gave to him mostly dealt with his hey, your muscles aren't activating how and when they should. We want to really get them turning back on and working through motion. So we actually never mentioned any of the disc stuff to him. Yeah, I'm very hesitant to use that word with people. And every time I do, it always comes with a disclaimer that, this is not a bad thing. I probably have disc issues in my back, but you'd never know it, so on and so forth. I don't like to use the D word in front of patients. Yes.
How were you looking at its comparable signs and just follow-up visits?
No, so the comparable signs we're looking at pretty much every time I put my hands on a patient and do something that I am looking for a change in the comparable signs, I'm assessing it right there. We just formally looked at it at that last visit, but every time we were doing manual, we were having it go into prone, and then we would assess it right there. So we were seeing small changes, like within the session, we do some manual work and then go back and assess, and you feel a little bit better. It wasn't as severe, like you guys weren't in here for Jake's, but his person had a big jump with the comparable sign, like within treatments. We didn't see that. We saw more between treatment improvements rather than within. Yes, Tom.
How was his compliance with the home exercise program with it being so many reps and stuff like that? Just curious.
He seemed to be really compliant. I know he bought in. He'd had a previous experience. Whoever had it for PT before must have done it.
So it sold. Okay.
Yeah, I must have done a great job because he came in just like, all right, what can I do at home? He was one of the people you'll notice that you run into a lot of people that you have to kind of speed up and make them do more, and then you got your people that you need to slow down and say, hey, you don't need to be doing like 3 hours of this every day. He was more of that people. So I would try to keep him to about 2 or 3 exercises, being that it was a lot of reps. And once he was feeling better, we sort of phased out some of the really, really high repetition stuff and gave him some more like the up chops and down chops is what he ended up doing at home. With, we gave him a handout at the end. In case this ever arises, we want you to have the tools to treat this on your own. So here are things that you can do at home that'll kind of help calm down some of that pain. Yes, Dr. Eagler.
So you know I'm going to talk about your 1 rep max.
I know you're going to talk about it.
So let me ask you this. When you did exercises, when you were looking at muscular endurance, did you go to 1 before failure?
No, we didn't do anything until failure. Generally,
Not till failure, till 1 before failure.
oh, no.
Because that's when you go, then you know you're doing in those ranges. Otherwise you can't, because you can do 1 rep max without doing a 1 rep max.
Absolutely.
You can do it through, but you have to look at, then you have to look at if you're going to, you don't want to do failure, because that's not a good thing, because you can have all that. You can do 1 before, so you can do that.
Yeah.
But with muscular endurance, you don't necessarily want to do that anyway. So I don't know. I'm gonna debate your ranges in there, but you're still doing some of the type things. I appreciate that you're at least thinking along those lines, because you know what specifically you're looking for in your what you're training the muscles to do.
Yeah. And generally what I would look for that kind of stuff, I want them to be able to perform all the repetitions with good form. But at the end, if you've done 30 repetitions of something, like those last 3 should be really difficult. You should be able to keep that form, but they should be tough. So I didn't necessarily bring it, but you can't do 1 more, but I wanted to ensure that he was doing a weight that would be tough to get that 30.
You know, you're training well when it's like, okay, I'm gonna, the patient says, I'm gonna
Absolutely.
put it in instead of stopping at an arbitrary number.
For sure.
I agree.
Anybody else?